Hello, everyone. Good afternoon. It's a tough slot, this, obviously, at 4:30. Everyone is going to have a long day, but we'll try and keep it interesting. Look, I'm going to talk about how digital can impact patient support programs and how to improve patient engagement and experience. I've been involved in designing patient services for about the last 15 years in S3 Connected Health. Made some mistakes, made plenty of mistakes. I'll talk about a few of those, and we'll talk a little bit about some of the lessons learned as well. Okay, so from a marketing point of view, everybody, I guess, whether you're in healthcare or another industry, has heard about the concept of moments of truth. And if you Wikipedia, basically what moments of truth says or means is it's the time at which consumers, or in this case patients, interact with a product or service, and they kind of make a decision about whether they like it or not, right? And pharma has been using this kind of concept for a number of years and has tried to identify standard points along a patient journey, which are these kind of key moments of truth. And that's all very interesting, and it's useful, and it has served us well. But in the digital age, there's another concept that's been defined, which is this kind of concept of micro moments. And I think it's Google that defined micro moments as this point when people reflexively turn to a device, increasingly a smartphone, to act on a need or to learn something or to do something. And I read last year that on average, apparently we turn to our devices for whatever reason about 150 times a day is about the average time people turn to their smartphone, which is a bit scary. But what it means then is, in terms of this new kind of digital world, that the opportunities to interact with patients aren't really defined just by these kind of standardized moments of truth, but they're defined by these kind of much more granular micro moments. So these points at which patients need something and you have an opportunity to provide them with a level of support. And the thing that's different between micro moments and moments of truth as well is moments of truth here, as you can see, you could define kind of standard moments of truth that you can imagine along the patient journey, whereas micro moments somehow are specific to each individual. So they're related to the person. So what might a micro moment look like in terms of patient support? It might be when a patient says, is the treatment right for me? What are the side effects that I'm having? What should I do about them? I'm tired of taking these injections. What happens if I miss a dose? I'm feeling better. Do I need to continue? And you'll see the word I used up there a lot. So again, these micro moments are related to human behavior and they're individual to the patient. And the opportunity for us is to see how we can support each individual patient with each individual set of micro moments that they have. And just thinking about this in a slightly broader context, there's a broader move, as most of you know, in healthcare towards this idea of really moving from episodic care to continuous care. So this idea that essentially we don't want to treat people when they arrive in hospital, but we want to more work with them in a proactive way to prevent them having these exacerbations or flares or reasons that they need to go and look for specific treatment. So we're trying to move the healthcare system in general from being a standardized model of care with kind of reactive support for patients to this much more personalized, preventative and proactive model of support. And if we can support people in these micro moments, then that's essentially what we're doing, what we're participating in, which is this larger mega trend in healthcare. So that's the scene setting bit. So the next piece is so if we want to help people essentially become better self-managers, and we want them to give them this more continuous support, essentially what we're doing is making them better self-managers, and to do that we have to influence behavior, and we have to influence human behavior. And to influence human behavior you need to know something about it, and you need to understand, for that particular patient, you need to understand their context, their specific patient context. And if we think about the types of support services that have been designed over the last few years and that are available now, they kind of start off typically with, providing some level of education, maybe some visualization that helps the patient understand how they're managing their condition, maybe provide some reminders to help them remember when they're due to take their medication. And that's all useful. It's a kind of an entry-level piece, but it doesn't actually change behaviors. The next level you might think about is when you take that information that patients are gathering and they're engaging with a service and you're providing them with some basic supports and you make that information available to a clinician. And that kind of clinical oversight definitely has a beneficial effect because patients now feel, actually I'm gathering this information, it's part of the way my care is delivered, I'm going to talk to my clinician about it. So they definitely get a bit more engaged. But that doesn't necessarily mean that when they leave the doctor's office that they're actually going to have changed their behavior or have become better self-managers or live a lifestyle that's better for their condition or be more adherent to their medication. So my argument is that the next kind of phase from those two initial things, which we've done several times in lots of different services, is that we need to start kind of thinking behaviorally. If we're going to try and influence human behavior, it means understanding the person, understanding the things that influence and impact their behavior, like personal things, societal things, environmental things. And then we need to use the science of behavior science to design kind of evidence-based intervention strategies that are going to influence patients' behavior. And we're not inventing something new here. This is the stuff that Facebook is good at. It's the stuff that Amazon is good at. It's the stuff that Netflix is good at. So what we're trying to do is understand how we can help patients in a positive way, engage them, and help them to form healthy habits around their condition, and help them become essentially better self-managers. So that's all good, maybe, but a little bit abstract. So I wanted to take just a kind of an example of a behavioral model. And this is one that was a result of the work by Rob Horne in University College London. And he came up with something called the necessity concerns framework. And what it looks at is, it was looking at specifically around the issue of medication adherence. And it was looking at what are the factors that determine whether somebody is going to be adherent to their medication or not. And when you look at them, it's reasonably common sense, but what he found was that actually people's belief in the necessity for the medication has a huge impact, and also their concerns about it. But what's interesting is that when you map people's beliefs into that framework, it does turn out that people who are in this area of having low concerns and a high belief in the necessity for a medication, common sense enough, they have high rates of adherence. And those that have low necessity and high concerns about their medication, they're skeptical about it, they're skeptical about the need for it, and very quickly become non-adherent, and they have the lowest rates of adherence. And the difference in adherence rates between here and here are really significant. They're like 4x difference in adherence rates. And taking that one step further, and this is a company associated with University College London, Spoonful of Sugar, that we do some work with. They did an analysis of patients, HIV patients, and they looked at how they map against that grid when you have no intervention. So when you have no specific patient support, when you're not trying to support patients during these micro moments. And what they found was, and if you can read it, it's repeating here a little bit, but as you go through the months, as you go to month 6, people naturally drift, without supports, they naturally drift up towards this kind of skeptical side, and they naturally become less adherent. So the reason for showing that is to say, and it's not the only behavior change model that we can think about, but specifically around adherence, it's a useful way to think about it around adherence. And what it says is that there is a science called behavioral science, and we can use the lessons learned and the evidence from those behavioral science strategies and think about how to integrate them and deliver them as part of digital patient support programs. Okay, so what might that look like in practice? So, well, if you want to understand patients and you want to understand the micro moments and you want to understand the challenges that they're having at different times, what you want to do is initially you want to gather some data. And you want to gather data that's going to be useful in terms of determining what challenges patients are having and how you might choose to support them. And the things you might gather, and we do in a number of services we've designed, is you might want to gather adherence data. You might want to gather biometric data if there's sensors that are relevant to the condition that patients are using. And that could be, sophisticated sensors, or it could be just activity monitors, for example. You certainly will want to gather information about their symptoms or any issues they're having with their condition, with their therapy. You'll want to gather information about their quality of life and their experiences. You'll want to gather information also then about their beliefs. So particularly if you're looking around something like medication, you want to understand, in terms of that grid and that necessity concerns framework, you want to understand what are their beliefs and how are they changing over time. And you want to look at the rest of the population data and understand what are the norms within the population. And you want to then have a behavioral model that will make decisions based on that data about what's the best intervention you can make for patients during those micro moments. And then you'll make an intervention. This is a very simple type of intervention. And the intervention that you choose to make should be driven again by behavioral science. So at a very simple level, if you look at this message, it's talking about Maria. We've noticed you haven't been getting much exercise recently. Well, we know that because you've told us, or maybe we've tracked it via an activity monitor. And you've reported that you're feeling tired. Again, we might know that because you've told us that. So immediately we're engaging, Maria. It's not a very generic thing. We know that you recently have just given us this piece of information, and we're addressing it specifically to you. We're saying then, look, doctors and experts say that both moderate and vigorous exercise is beneficial for women with atrial fibrillation. So again, it's smart enough to say, well, first of all, I know you're a woman. I know your name. I know you have atrial fibrillation. I know you've been having some issues recently. And here's some useful advice. And I might also know from the information I'm gathering about you that actually you respond pretty well to scientific information. So I might say, look, a new study of 380,000 patients like you has found that, this is very good for you if you can get a moderate level of exercise. So it's a very simple example, but something that could be quite relevant for the patient, and essentially is addressing the issues that they have at a specific moment in time. And of course, it's different for every patient because patients are going to be different, and their challenges and their micro moments are going to be different. And the couple of examples I've given are relatively simplistic, where you're really essentially trying to give them the right information, the right kind of nudge at the right time to help them modify their behavior. But actually, the behavioral constructs that you can build into services can be more sophisticated. They can be around, for example, habit formation and helping people replace poor habits for good habits. So far I've talked a lot about just behavior change and its role in terms of designing patient support services that are meaningful for patients, and they are a key part. But they're not the only, they're kind of I think a necessary but not sufficient condition for success, essentially. And that's because services, and it's a kind of an obvious statement, but services need to be designed. And services aren't just about technology. Services are about the digital pieces, they're about the non-digital pieces, they're about the process that you put in place around it, they're about the launch strategy, the go-to-market strategy, the change management support that you give clinicians if you want them to be part of it. So services are much more than just the technical elements that you might design and build to deliver them. And designing good services is about, and I know people use these terms a lot, but it is about co-creating with patients. It's about understanding their unmet needs, understanding where these micro moments might be, and analysing behaviours and coming up with the right behavioural strategy. And in terms of co-creating with clinicians, it's about recognising the challenges that they have. They're humans as well. They're time poor. They're not looking for things that are very distinct. They're looking for things that are going to enhance the way they deliver care, not change it or replace it, typically. And this is an example of a service that we have been running for about 6 years. And it's delivered about 2 million monitored patient days, so we've a reasonable amount of data coming from it. And I just present it as kind of an example of what I hope is a reasonably joined up service. So in this service, this is a service for patients, it's paid for by the NHS actually. It's a service for patients who have CHF, COPD, diabetes, stroke. And the service model essentially is that patients, it's a telehealth type model. Patients will self-monitor their condition, typically on a daily basis. They'll provide information, PRO type information about how they're feeling on any given day. That information and what they provide will be available to their carers. And then there'll be a number of levels of management of that information, essentially, and proactive reaction or proactive handling of that information. The first level is a kind of a digital triage level where the digital piece of the service will look at the data that's coming in, compare it to a care plan that's been set up by the clinician, and identify patients who are outside of that care plan. And when that happens, that's reviewed then by a nurse, in this case. And the nurse will review patients that have these exceptions and will decide what to do. And maybe they just give them a call and see how they're doing and double check in on them. Or maybe, in a small proportion of cases, they escalate that to community nurses. So this service is designed actually primarily for elderly people to keep them from having frequent visits into hospitals, and that's why the NHS are paying for it. So the clinical nurse in the call centre and the triage centre can escalate to community nurse. That's synced up with from a workflow point of view, that's synced up with the community nurse's day. So the community nurse typically will review patients in the morning and go visit them in the afternoon. So the escalations that happen from the call centre clinical triage to the community nurse are in the morning so that they can schedule things in the afternoon. And then that information, and then the community nurse can decide to escalate to a GP or a clinician. So that service, which took a long time to co-create with patients and with carers and with clinicians, is what I would say is an example of a joined up service. And the good thing about when you design good patient services is, you kind of know when you get it right, because you get feedback like this. And this is some of the feedback we've got from patients on that service. You feel in control, not somebody else. You feel in control of your own health and what's going on. It gives you a certain amount of independence and responsibility that you're not relying on somebody else all the time. Or it gives me knowledge of my condition and lets me know what to keep an eye on. It also makes me feel more involved. So these are signs that patients are getting what we think they need, which is they're feeling more informed, they're feeling safer, they're feeling a bit more in control, and they're feeling understood and empathized with, essentially, by the healthcare system. So then, so we talked a little bit about behavioral science and the role of behavioral science. We talked a bit about the need to design these kind of holistic services that are joined up. Just the last bit I wanted to touch on is just where digital helps. And I think where digital helps is really in the scaling of this, because it's possible to design these services on a small scale, and that's been done. There's been thousands, literally, of pilots that have done around these types of services. But the challenge is, how do you design these things at scale? And I think that is where digital helps. So again, what we're trying to do when we think about a digital infrastructure to support these types of services, we're thinking about how can we be there for these micro moments throughout a patient's journey. How can we understand as much as possible about the challenges that a patient's having at any given time, and how can we have a sensible level of support to support patients in those moments. So the ingredients then that you need to provide these services is you need a number of touch points for patients. Typically it's going to be a smartphone, but who knows, a couple of years, maybe it's going to be your Amazon Echo, maybe it's going to be your virtual assistant. Doesn't matter, but essentially with patients we're trying to make them feel these things of being understood, informed, safe and in control. Then you need if you like, what I'd call a behavior change engine. You need an ability to take behavioral science and the evidence from that and deliver interventions based on a behavioral model that can support patients at the right time. You need a way for clinicians to access the information, and you need a way to essentially put that information and use analytics to gain insights from it. And these are the building blocks, I would say, for delivering services at scale, because again, smartphones really have only been around for a small number of years. Cloud-based services that are, let's say, easy to develop and deploy, again, have only been around for a number of years. And what you want to be able to do, particularly as pharma companies, I think, is you want to be able to design a service that's going to scale across 30, 40, 50 countries. That's now possible to do because of cloud-based technologies and services. So last slide almost. Summary, I would say, is digital gives us tools to engage patients in these micro moments. I think we can use behavioral science to understand the patient journey and tell us how to intervene effectively. And if we do it right, it results in increased patient engagement, better insight and evidence, improved outcomes, and brand differentiation. And in a survey we did a couple of years ago, or actually, sorry, not a couple of last year, 94% of pharma people that we surveyed believed that payers and providers wanted pharma to provide these services. So it's kind of like a moment of truth for pharma. And that's pretty much it. We have a stand outside. Be happy to talk to anyone afterwards. Been doing this for a number of years, and again, happy to share any experiences we have around that. That's it.
So I think we've got some questions for you.
Okay.
Thanks for that. For me, from my point of view, it's fantastic to see the kind of capability that's possible to genuinely start to help people with health conditions or illnesses, more than just some of the tactical things that have been done myself and others over a long period of time. Really a structured and consistent way of doing it. I think it's a really interesting opportunity. The question we have here is, do you have any metrics to demonstrate the reduction of hospital admissions since you rolled to the NHS?
Good question, hard question, whoever asked it, anonymous. So we do have some metrics and reports, and I'd be happy to share them afterwards. It was a service that was designed essentially initially really to help the healthcare system cope with demand. So we measured things initially like soft measures, which you have to measure at the start of these things. Are patients engaging? Yes. Are patients adherent to the service itself? Do they engage with the service a long time? And actually our adherence to the service itself, so people monitoring, self-monitoring on a daily basis, was about 97%. So patients are engaged, patient satisfaction is very high, clinicians appreciate the service and recognize the value of the service. There were specific studies that were done on the diabetes side around reductions in HbA1c levels. There were studies done around the COPD cohort of patients as well. Again, happy to share the research on that. And the bit that I'm going to get to is there was also a study done to try and understand the impact, the health economic impact. And that's a much harder piece to do, because when you're dealing with patients over a long period of time, and if you don't run this as a randomized control trial, which it wasn't, it was a mainstream service, it can be difficult to get the matched cohorts to compare it with. So we have lots of, I would say, anecdotal evidence. There's a good bit of research and research studies that have been independently done around it. But I would say, I don't have the clear figures that I can say this absolutely reduced hospital admissions by X. What I would say is that in design, it's very similar to a number of other services. So within the VA, for example, in the US, they've about 100,000 patients on services like this, and what they've seen is about 20% reduction in hospital admissions. There was a randomized control trial done in the UK about 6 years ago, about 8 years ago, called the Whole System Demonstrator, which again showed similar reductions in hospital admissions, reduction in A&E visits, again 20% typically.
Great. The metrics and all of that are obviously very important for then further justification either inside of pharmaceutical companies or to other healthcare providers. Very good question. How will GDPR affect the patient support program strategies? Any thoughts on that, Jim?
Yeah, I mean, we're spending a lot of time looking at it. It certainly, it kind of raises the bar in terms of what you need to do, but not to an unreasonable level, not to an undoable level. It just means that when you're designing services like this, really from the start, you have to consider the implications of GDPR, and you have to design those kind of capabilities into both the technology and the service and how it's going to be delivered. I think it'll raise the bar in terms of, I would say, meaning that there's going to be the need for a bigger upfront investment in the core infrastructure to deliver the services, which means, again, that actually it'll tend to favor services that are going to be delivered at scale rather than services that are going to be delivered in a kind of a small local pilot, let's see if it works kind of way. And typically that's what we would advise anyway, is that you design, you think about designing services for scale, for global scale, even though you might pilot it in a specific country, initially, or you might pilot it in a smaller way initially, but you have to design the infrastructure for scale.
That's great.